Good morning, ladies and gentlemen. I warmly welcome you all to the specialty update in in acute medicine organized by Ceylon College of Physicians in collaboration with Sri Lanka College of Internal Medicine. We have today Professor Arosha Disanayake, President Ceylon College of Physicians, and President of Sri Lanka College of Internal Medicine, Dr. Ganaka Seraratna, as well as four eminent speakers, Dr. Krishanta Jayasekara, Dr. Suranga Manilgama, Dr. Anoja Rajapaksha, and Dr. Priyamali Jayasekara, who will be talking to you on very important topics in acute medicine. So after each topic, you will be given a chance to question and answers. Now, there will be a Q&A answer button in your right-hand side, the bottom side of the screen. So you can always direct your questions to that, clicking that button. So without further ado, let me invite Prof. Arosha Disanayake, President, Ceylon College of Physicians, to brief you on today's event. Over to you, Prof. Arosha.
Thank you, Madhuvanti, for starting off the program. It is a great pleasure to very warmly welcome this audience for today's important meeting. As we know, every month in the CCP calendar has a particular specialty, and we work with a sister college to give very evidence-based, up-to-date, to impart evidence-based, up-to-date knowledge to the practicing doctors of Sri Lanka. And this is the month of August, and the month of August is Acute Medicine Month. And then for this endeavor, we have engaged the Sri Lanka College of Internal Medicine to speak to us about important areas, 4 important areas in acute medicine. It is a great pleasure and a privilege for me to have by my side virtually Dr. Ganaka Seraratna, my very dear friend and colleague, Dr. Ganaka Seraratna, who is the president of the Sri Lanka College of Internal Medicine, as the chairperson of this session. Again, we have 4 very eminent speakers. I warmly welcome them. The president of the Krishanta Jayasekara, who happens to be the president of the Galle Medical Association, is also here with us. Then in addition to Krishanta, we will be having Dr. Suranga Manilgama, and then Dr. Anoja Rajapaksha, and then Dr. Priyamali Jayasekara, who are 4 leading lights in the field of medicine in Sri Lanka. And I'm sure we will gain much expertise. So this is, now we've already had from the acute medicine a college lecture earlier this month. And there we have this session. And then, of course, this will be followed up by the acute medicine quiz, which will be put up and people can actually win prizes. And most of the questions will be based on today's lecture. So I wish you good luck for all that as well. And I will hand over now to Dr. Ganaka Seraratna to take on from now and then conduct the program and the Q&A sessions to be handled by Dr. Madhuvanti Hettiarachchi. Thank you very much. Over to you, Ganaka.
Good morning. Thank you so much, Arosha Disanayake, President, Ceylon College of Physicians, and the Council for giving us the Sri Lanka College of one of the most important aspects of our day-to-day life, which is acute medicine. In a personal note, I share this meeting virtually with Prof. Arosha Disanayake, a person whom I admire most as a friend and a teacher. So I would like to, at the outset, I would like to welcome all of you and thank especially all these 4 speakers to taking their time off, share their expertise. And in the same manner, would like to appreciate our live wire, Dr. Madhuvanti Hettiarachchi's work, who has been the live wire and setting up all this program for us today. So without taking much time, let's move the first talk of the day that will be on fluid management in dengue. The first speaker is Dr. Krishanta Jayasekara. He's the specialist in internal medicine and consultant physician in Teaching Hospital Karapitiya, and has been working in this acute medicine field for a long time. May I invite Dr. Krishanta Jayasekara for his lecture on fluid management in dengue. Over to you, Krishanta.
Thank you very much, Kanaka. Okay, so my talk is going to be fluid management in dengue, getting the basic concepts right. Now, if you just look at what the local experts actually expect from you, and what they have commented is that majority of dengue deaths are with complications due to prolonged shock or fluid overload. And they expect 99.9% walked-in patient should walk out. Even patient who come in shock without a prolonged shock, more than 99% should survive and go home. So is this achievable? So we know that two major causes are due to fluid shifts, and if you manage them appropriately, you can prevent deaths. So my talk would be basically start with some pathophysiology of fluid distribution in dengue, which I will only spend a couple of minutes. Then I will be going through the fluid management during ambulatory phase, pre-critical, critical, during dengue shock, equilibrium, and fluid overload in a case scenario-based pattern. So if you look at the physiology of fluid distribution, now 60% of body composition is fluid and 2/3 is intracellular. Is only 1/3 which is extracellular. Out of that also only 20% is in plasma. So we need to manipulate the plasma component because the pathophysiology of dengue lies with the fluid leakage of plasma to the interstitium. So we'll see now these are the typical phases of dengue, and this is what happens if you do not manage the fluid status appropriately during each phase. During febrile phase, if you don't take adequately, you might end up with dehydration. During critical phase, if the patient goes into profound shock, they can go into organ impairment and multi-organ failure. They can bleed, and also that can also lead to multi-organ dysfunction. And then during the recovery also, sometimes what if the leakage has been massive, their reabsorption can lead to pulmonary edema, or if you give inadvertent fluids. So these are the things, mishaps that can happen during the fluid management of each and every phase of dengue. Now we'll start with a case scenario. A 23-year-old undergraduate presents to his GP with fever, headache, severe body aches for 3 days. He was pyrexia, flushed, and had normal hemodynamics. He weighed 68 kilos. Following blood reports were requested by the GP. His full blood count, hemoglobin 13.2, PCV baseline was 38, WBC was 3,400, and platelet 180. And he, for confirmation, did a NIS1, which also was positive. And so he was advised on ambulatory care and was advised to come back after 24 hours with a repeat full blood count. So he went home with the advice. And so type of fluid, usually what we advise them is to take, salty fluids, and the minimum of we just say, so we could say a minimum barely to maintenance 1.5 to 2 ml per kg per hour. Then maximum sealing, there is no maximum sealing, but you can, for your thirst, you can drink, but not, you should not drink excessively. So, and you need to be mindful about the insensible losses, high fever, if there is any diarrhea, vomiting. So those should also be accounted when you advise patient on fluids on during the ambulatory care phase. And we obviously warn about warning symptoms, and then we have to be a little mindful about the special groups, especially the children, the elderly, or patients with multiple comorbidities. So this is how we would manage the ambulatory care. So the patient comes back next day with ongoing fever, has nausea, vomiting, restricted his oral intake, but was able to take and apparently had a good urine output. And he comes with a repeat full blood count where the PCV has gone up to 40 from 38, platelets have dropped to 118, and WBC has also dropped. So he was recommended inpatient care and was admitted to medical casualty. On arrival, the house officer has, this is the vitals on admission, temperature of 102, pulse of 100, pulse pressure was 55, and then capillary refill less than 2 seconds, air intervals equal. He was started on a 3-hourly observation chart. So I will only be talking about the fluids because other things would be a scope of my talk, out of scope of my talk. So fluid management, we would recommend, so the house officer has recommended either to take oral, if not IV. So recommend about 2 ml per kg, about 100 ml for this patient. So this is the chart that we commonly use. It's when the platelets are less than 130, and the same chart, we have formulated another one on your right with the input-output chart also incorporated into the same 3-hourly chart. So that gives a basic view of how the patient's overall picture. Now, this is the patient's chart, and you can see the patients being initially managed with orals with very good urine output. And subsequently, during nighttime, I suppose a patient would have requested some fluids to, have to minimally disturb the sleep. So given some IV fluids, but still the patient had very good outputs and all the vitals had been normal. So next day, the patient, day 2, that is day 5th day of fever, fever continues, body aches, and you did a full blood count in the morning, and the WBC 3,400, it started to go up. On your right, you had the previous days. PCV has jumped further up, gone up, platelets have dropped further down. The patient is on oral maintenance during day and IV maintenance at night. So should we change fluid management? So the fluid management changes will be decided by whether the patient is entering into critical phase. So now I'm not going to talk much on the critical phase criteria, but there are clinical, hematological, and radiology. But since the radiology has become a sort of a gold standard today, would tell a little bit about the few facts about the point of care sonography, where we do a focus scans to look at 5 things: gallbladder wall edema, pericholecystic fluid, fluid in the pelvis, fluid in hepatorenal pouch, or right pleural effusion. Mind you, the top 3 can even be seen in dengue fever, right? So we did a scan, its scan was negative, and then that ruled out leaking. So we moved to the next day of illness, day 6. And then the patients become apyrexial, with faintish abdominal pain, vomiting. And the patient's pulse rate has gone to 90. PCV has jumped for little further up, which is 38 baseline. Now it's gone to 44, and full blood count was sent. And probably this patient now is entering to critical phase because there's a rise in PCV. And there is probably with the settling of fever and some symptoms of entry into critical phase. So what is your fluid management, right? So you got the confirmation with the ultrasound that the patient had a 4 millimeter fluid rim in the hepatorenal pouch, which was done at 10 a.m. And how do you define the onset of pre-case? Sometimes, so you detect at 10 a.m. So how do you define the onset? It sometimes might be a little difficult, but always there are certain surrogate markers that you can go by: the time that the fever subsided, the platelet drops less than 100, or whether the time the WBC started to rise. And but it can be more objective if you do it with a scan. And so these are the certain things that you could use to detect the onset. If there's gallbladder wall edema, you need to repeat after 3 to 6 hours. Potentially, they might go into leaking very soon. Pericholecystic fluid also maybe partly due to dengue, but you need to repeat the scan after 2 to 3 hours. But if you have a fluid rim in hepatorenal pouch, that you need to take it as around 6 hours from the onset. And if there is right pleural effusion, 12 hours. And if there is pelvic fluid, we will go, it's probably the patient has gone more than 24 hours into the critical phase. So this is how ultrasound will help you to define the onset of, because your fluid management will depend on the timing of critical phase. So you calculate the fluid for your particular patient once you detect the critical phase. And this patient, since the patient is about 50 kilos, we take it as 50. And then it comes to 4,600 as a total of intake for duration of critical phase, that is 48 hours. So how should you give this 48 hours? If you take the 48 hours in each 24 hours in 6-hour quadrants, you can go 1.5, 3, 5, and you pick up with 7 depending on the patient dynamics, right? So if you divide with the equal volume, it is 95 ml power, but usually we do not give it a uniform rate. So we can start with 1.5 to 3 depending on the patient's hemodynamics, and then you can change according to the vitals. So now, so this is the usual what you would see in a the patient will have. Some people with the typical is a moderate leaker with a pyramid type of a leak, fluid leaking. Then there are rapid leakers who will leak within the first 6 hours to the peak and then will gradually slow down. Then there are slow leakers who will peak around 36 hours. And they are the commonest that you will see, luckily, are flat leakers, where they will have a very uniform flat leaking, and their vitals are going to be very stable. And we are lucky because majority are flat leakers. Now, how do you define whether your leaker is a moderate leaker, rapid leaker, slow leaker, or flat leaker? So there are 5 pearls that I'm going to talk. 1 is pulse rate, number 2 is pulse pressure, number 3 is capillary refill time, number 4 is urine output, and number 5 is PCV. So this is, I'm going to the case back again. Patient has started on fluids 2 ml per kg, 50 ml, 50 oral started, 5 pearls checked after 3 hours, right? So when you check, so on your right, you have the new pearls, and you can see that there is the pulse has gone up. Pulse pressure is dropped further. Capillary refill time remains the same. Urine output is borderline, and PCV gone by 2. So what is your subsequent fluid? So I will not continue 2 ml because it does seem little inadequate. There is no indication for boluses. So I will increase the fluid to 3 ml. Now this is where I would be. So I would start at 2 ml, then I went up to 3 ml. Now, so this is, so the start, so now I have, by 6 hours, I have given 1,350 fluid quota is already given. Now, 3 hours later, his pearls were reassessed. On your left, you have the previous, and then after 12 hours, you see the pulse rate gone up by significant value, right? Up to 112, and then pulse pressure remains still low, 24. Capillary refill time actually is more than 2 seconds, and urine output has dropped to 15 ml, and PCV has gone further up. So now what should your management? The patient was on 3 ml per kg. So should you continue 3 ml? Should you increase it to 5 ml? Should you give a crystalloid bolus, or should you give a colloid bolus? So at this point, because this patient shows some features of a compensated dengue shock. So compensated shock is where you can have 2 or more, either tachycardia more than 110, pulse pressure less than 20, capillary refill time more than 2 seconds, so urine output equal or less than 25. So this my patient actually fulfills the criteria of a compensated shock. So what I would do is probably this patient is going into shock. The leakage is the commonest cause of shock. There could be hemorrhage, or there is very few patients can have both bleeding and leaking leading to shock. So the pearl here would be the PCV. So you do a leaking, the PCV should go up. Bleeding, the PCV should come down. Leaking plus bleeding, either it should be normal or should come down. So this is how a PCV is going to be helpful. So what I will do is I will start with a 10 ml per kg bolus over 1 hour, and we'll see how the patient proceeds after that. So this patient receives a 10 ml fluid bolus. Then you repeat your pulse after 1 hour. So, and you can see the pulse has come down a little. Pulse pressure is slightly pulse pressure still remains 26. Capillary refill time is now less than 2 seconds, but urine output low. PCV is 47. So what is the expected PCV drop after this thing? So we'll see. So what should you do now? Can you come down onto 5 ml, give another crystalloid bolus, give a dextran bolus, give 250. So my choice would be to give another crystalloid bolus. So before that, crystalloid, now what will happen to PCV with after bolus infusion. If you give 10 ml crystalloids, drop by 5. If you give 10 ml dextran, it should drop by 10. Dextran 5 ml should drop by 5. Blood 5. So this is what we call a 5 and 10 rule in dengue, which will make your life a little easy to remember. So what if the PCV does not drop as expected after? So my patient's PCV did not drop by 5. So that means that the patient is leaking more than what I'm giving. Or if it drops more than that, the patient is bleeding. So these are the two facts that are important after bolus. So this is, so the patient, the second crystalloid bolus. And now the patient's vitals after second bolus. So the pulse rate has gone further up. Pulse pressure has come down. Now capillary refill time again has gone up. And now urine output is still not sick. And even after the second crystalloid, the PCV has gone further up. So what should you do? Now you are given 10 ml, you come down, you give another crystalloid bolus, you give a dextran bolus, or you give 250 ml blood. So my choice would be to go for a colloid bolus first, right? So before I give my boluses, I will also consider ABCS. So this I have given a colloid bolus. Now I have given 2,850 by 18 hours into or 16 hours into his leaking, right? So dextran is the best that we use as a colloid, and you can give up to 3 boluses, and you can use hetasarc if you happen to give more than 3 boluses. So now dextran 10 bolus is given, and now you have assessed the vitals, right? So the patients actually, the vitals have stabilized. Pulse pressure has increased, pulse rate has come down, capillary refill time is less than 2 seconds, and urine output is now 25 ml, and then the PCV has gone down by 8. So the expected PCV drop is 10, but it's dropped by 8, and the patient's vitals have improved. Now I am happy. So what should I do next? Should I come down to 7 ml per kg? Should I give a 3 ml per kg crystalloids? Give another 5 ml dextran bolus, or give 250 ml of blood? I would come down to 3 ml per kg. Right, so I have given a 3 ml per kg. So now here I have started at 10 ml, given 3 10 mls, 2 crystalloid colloids. Now I will, since the vital stabilized, I came down to 3 ml. Now, so what are your treatment goals after when you manage? You should keep your systolic blood pressure above 90, keep your pulse rate below 100, keep pulse pressure above 30, urine output above and around 25, and CRFP less than 2 seconds, and stable PCV. So you might not have all 6, but 4 or more would make you a little happy that you're winning. So we were happy, and we started managing with crystalloids, right? So we have started going on with 3-hour fluids, and then after 3 hours, you reassess the patient again. Patient again has deteriorated. Now the pulse rate has again gone up to 110. Pulse pressure has dropped again to 22. Capillary refill time again is more than 2, and urine output has also dropped, and the PCV has dropped by 5. So this is something that I did not expect the PCV to drop. So why did the PCV drop? So what is your management? Come down onto 2 ml per kg for next 3 hours, which will not be the ideal. Give another 10 ml crystalloid bolus. Because the patient's PCV has not gone up, I will not go for a crystalloid bolus. Dextran, same, I will not go for a dextran bolus. So I should give there is definitely concealed bleeding, right? So I should give a blood 250 ml over 1 hour. So what are the indications to transfuse blood? So drop in PCV with unstable vitals, absence of expected PCV rise in unstable leaker, refractory acidosis are the indications to give blood. So I have given 250 ml blood over next hour. So this is pulse after blood transfusion, right? So you given, then your pulse rate has come down on your right. You have the yellow bar is the new vitals. Pulse pressure has very nicely increased to and 32. Capillary refill time has come down. Urine output has improved, and PCV also has risen by 6. So you know that you're winning here. So the blood. So what is your next management? So you actually, the blood has done the job, its job. Now how should we? Right, okay. So dextran 10 ml will be out. Crystalloid another bolus again will be out. Another blood, there is no indication, and we will go for crystalloid 3 ml per kg per hour. So the patient was subsequently managed with, so by the end of 24 hours, the patient has already received 3,700. So the patient was given 2 ml, then was cut down to 1.5 ml per kg, and patient's vitals remain very nicely till say 42 hours. So 40, right? Okay, 42 hours into critical phase, you have repeated the vitals and you can see the pulse rate has come down, pulse pressure is high, capillary fill time is 2 seconds, the PCV is now slowly rising, urine output is borderline. Now there is a concern because the PCV has, which was a baseline around 38, it was 40 to 44, has further gone up to 46. So what should you do? Patient's fluid quota is also now nearing completion. So dextran 10 ml, dextran 5 ml bolus, crystalloid 3 ml per kg, omit IV and continue oral only. But the vitals are stable. So what phase of illness? So this is what we call a equilibrium phase, where there is neither leaking, neither reabsorption. It can last for about 24 hours in a profound leak, like in this case. And this will be a little challenging if you don't pick it early and treat accordingly. The patient can have dire consequences, right? So usually this happens in the latter part or end of leakage, usually seen in profound leakers. And do not try to correct PCV if the pearls are stable. And as in this case, close monitoring till the patient enters polyuric phase. So what we did was we actually omitted IV and we continued oral only, right? So then something else happened overnight, right? So equilibrium was initially managed, but then the patient had persistently high PCV and the on-call medical officer thought that the PCV side, we should give some more fluid, and they were infusing 3 ml per kg overnight at a flat rate. And by the latter part of critical phase, the patient has received 5,800 ml and the patient started to show signs of fluid overload. So fluid overload in dengue is something which is challenging. Usually second half or latter phase of leakage, only in profound leakers, when you give excessive fluids during leakage, and can be seen even with excessive oral intake, with puffy eyelids, tachypnea, tachycardia, and low output, and it's important to diagnose early and treat. So this is what after 48 hours you see, and you see the pulse rate is 110, pulse pressure is maintained, capillary fill time is again prolonged, urine output is low, PCV has gone up. So should you give dextran 5 ml? Should you give dextran with fusimide? Should you give a crystalloid 1.5 maintenance, or omit IV and continue liberal oral fluids? So what should be your management? So this is a fluid overload which is unstable, and patients, so I will go for dextran with fusimide. So dextran bolus of, or what we call a half bolus dextran, is another way of giving dextran, and it can be given alone in a patient with a stable with a fluid quota nearing completion, or with fusimide in a patient with a fluid overload. Right? So this is a challenge, fluid overloads. We know half of the patients died due to fluid overload. So fluid overload in dengue, you divide them into two, unstable or stable. Our patient had unstable with high PCV, and we decided to give 5 ml dextran over 30 minutes with a fusimide 0.1 milligram at the midway. The patient had low PCV, I would have given blood transfusion with fusimide. Then if the stable high PCV is what we call like equilibrium phase, masterly inactivity. If stable with low PCV, you can give IV fusimide alone. So this is how you manage fluid management of fluids during fluid overload. Now, in summary, ladies and gentlemen, so understanding fluid dynamics in various phases of dengue is important. 5 pearls are the deciding tools in fluid administration during critical phase. Precise decision in timing of crystalloid boluses, colloid boluses, blood transfusion will achieve the motto that we wanted to achieve, that is 99.99% of walked-in patients who come to hospital with dengue should walk out from hospital. And even those who come in shock, but without prolonged shock, should have a more than 99% survival. Thank you very much.
Thank you very much, Dr. Krishanta Jayasekara, for that wonderful lecture. Actually, I think there are about 1 or 2 questions. First one is They want to know whether the colloid boluses and red blood cells, if given, are included when you are calculating the amount of fluid given.
Yeah, the blood is usually not calculated to the quota because it is to replace the amount of blood loss, but the colloid boluses are definitely calculated for the fluid quota.
And there's another one, it's not little clear. They want to know whether we should come down gradually after bolus, 753 like.
Yeah, that's right. Usually, now it all depends on the patient's fluid status. At the now, certain patients, by the time we give fluid, they have received quite a significant volume of crystalloids or colloids. So, in that sense, depending on the patient's vitals, so 10 ml, usually the recommended teaching is to come down to 5 and come down to 3. But you can straight away come down to 3 and reassess the patient, and then you can go up to 5 depending on the patient's 5 pearls. So my advice, 10 ml crystalloid bolus, come down to 3. If there is any deterioration, you can go back up to 5, or you can come down depending on the to 1.5 or 2 depending on the patient's further response. That all depends on the amount of fluid that you are given at the time of patient received boluses.
I think the next question is, you have already answered that. She want to know whether it was cut down to 3 ml per kg. So you have answered it. So in the absence of any more questions, I think it's time to move on to the next talk. Over to you, Dr. Ganaka.
Right. Thank you so much, Krishant and Madhuvanti. Thank you, Krishant, for that wonderful talk on getting the basics correct. I would like to invite you to accept our certificate of appreciation, which will be delivered through the email for the wonderful, for your dedication shown for this particular symposium on acute medicine. Thank you very much, Krishant. So, ladies and thanks. So, ladies and gentlemen, we are moving to the second talk of the day. That will be on diabetic emergencies. So this will be done by our own Dr. Suranga Manilgama, our editor of the Asian Journal of Indian Medicine, which is the Journal of Sri Lanka College of Indian Medicine. Suranga is working as a consultant physician at Colombo North Hospital, teaching hospital. And he has graduated in 2002 and obtained his MD in 2010 and obtained his MRCP 2011 and obtained his fellowships from both colleges in London and Edinburgh and the American College of Physicians as well. And he has obtained his MRCP Specialty Diploma in Diabetes and Endocrinology from And he has become the first Sri Lankan to receive the prestigious Global Academic Fellowship from American College of Physicians in 2019. And he completed the fellowship in diabetes at the Mayo Clinic. And he has authored many number of articles, including 40 peer-reviewed journals. He's been working as a office bearer in many professional colleges. He has been our own founder, secretary, and secretary of CCP. Treasurer of CCP, and now he is the editor of our journal. And he's the examiner in postgraduate and undergraduate examinations, and he's examining MRCP cases as well. So, Suranga, it's over to you for your talk on diabetic emergencies.
Thank you, Ganaka. I thank CCP and SSM for jointly organizing this acute medicine update and for giving me this opportunity. And today my talk is on diabetic emergencies. I will go through a few case scenarios in my talk, and let's start with the first case vignette. A 20-year-old woman admitted drowsy and disoriented since waking up in the morning, has been unwell for 3 days with fever, dysuria, and suprapubic pain. She has vomited few times, and she was previously healthy. On examination, she had GCS of 14 out of 15. She was a bit disoriented and confused, had temperature, and she was tachycardic, and blood pressure was 80/60 with hypotension. and saturation was normal. Abdomen, other than suprapubic tenderness, was soft, and there were no other neurological deficit. So what are your thoughts? Could it be urinary sepsis with septic shock? Or could it be gynecological emergencies? But she has had menstrual period, last menstrual period 2 weeks back. And could it be metabolic derangement? Yes. Drug overdose, but there is no such history. So how do you manage in the acute setting? So AB is normal, airway breathing is normal, circulation is in danger, so need to put IV cannula, wide IV cannula, and start fluid resuscitation. So what is the most appropriate immediate investigations? These all investigations are needed, but the most important thing is capillary blood sugar. So it came as 510 milligrams per deciliter. So what are your diagnoses? Could it be diabetic ketoacidosis, hypoosmolar hyperglycemic state, or could it be hyperglycemia, glycemic state with sepsis? Yes. So what are the further investigations you are going to order this patient? So we need to do blood gas analysis, ketone analysis, and we need to confirm the blood sugar with venous plasma glucose, electrolytes, renal functions, and looking for features of infections, inflammatory markers, and cultures. But are we supposed to do CT brain? No. So see, except CT brain, HbA1c and lipid profile, rest of the investigations are needed. Yeah. So the urine ketone bodies came as 3 pluses, and blood gas analysis showed pH of 7.1 and bicarbonate of 8. And she has had CO2 of 20, was washing out carbon dioxide. So what is the diagnosis? Diagnosis is diabetic ketoacidosis. So it is a medical emergency with the biochemical triad of hyperglycemia, ketosis, and acidosis. It can occur both in type 1 and type 2 diabetes. So what are the diagnostic criteria? Blood glucose more than 200 milligrams per deciliter, or known to have diabetes in the past history. Capillary blood ketone levels more than 3 millimoles per liter, or significant ketonuria, we take it as 2 or more pluses. Bicarbonate less than 15, and or venous pH less than 7.3. Presence of all 3 criteria are needed to diagnose diabetic ketoacidosis, and the standard care is venous blood sugar, not the ABG. Arterial is indicated only if patient has got hypoxia. So what are the aims of management? Restoration of circulatory volume, clearance of ketosis and suppression of ketogenesis, correction of electrolyte disturbances, and reduction of blood glucose. So these are the important aspects in management of DKA: IV fluids, insulin, potassium replacement, and also correction of acidosis, close monitoring, correction of precipitating factors, and prevention of thromboembolism. The most priority goes to restoration of circulation. So yeah, when it comes to IV fluids, so when to start? There are 3 questions to answer: when to start, what to start, and how to give. So when to start? As soon as DKA is suspected. And what is the fluid of choice? Is 0.9% sodium chloride. How to give depends on the blood pressure. So in our patient, she has had systolic blood pressure of 80. So when the systolic blood pressure is less than 90, you have to give normal saline, 500 ml over 15 minutes, then assess the blood pressure. If it is remain low, then you can try with the second pint. So altogether you can give 1 liter. Usually with 1 liter, their systolic blood pressure will go up to more than 90. If it remains low, then you have to look for the coexisting some other pathology like cardiogenic shock or septic shock. Once it is more than 90, then you can go continue the fluid quota: 1 liter in 1 hour, 1 liter in next 2 hours, 1 liter in next 2 hours, so on. And you have to remember, you need to add 10% dextrose once blood glucose level drops to 250 milligrams per deciliter to normal saline. In that case, you have to continue both dextrose and normal saline, and KCl to be added from the first liter of blood fluid infusion. So when it comes to insulin, how do you give insulin? When to give? Once DKA is diagnosed, but only after starting fluid resuscitation. And you have to make sure that potassium is more than 3.5 before starting insulin. If it is less than 3.5, you have to replace with potassium. And what to give is human soluble insulin. How do you give? It's with fixed rate intravenous insulin infusion. The dose is 0.1 units per kg per hour. So how do you prepare your insulin infusion? So take 50 ml syringe, add 50 units of soluble insulin into 49.5 ml of normal saline. Then this chart shows how to calculate the insulin rate according to the body weight. So if that patient is on long-acting basal insulin already, you have to remember and you have to continue this basal insulin at the usual dose and usual times. And is there a place for bolus dose insulin in DKA? Usually there, routinely, it is not recommended, but only if there is a delay in setting up infusion, you can consider giving bolus. That is, yeah. So at the presentation, they might have when it comes to potassium replacement, at the presentation, they might have low, normal, or high serum potassium, even though the body potassium is low due to osmotic diuresis. But after starting treatment, potassium will move into the cells and serum level drops drastically. And you need to anticipate this and replace with potassium. So how do you replace potassium? You need to maintain potassium between 4 to 5.5 millimoles per liter, and you need to add KCl after 1 liter of normal saline, and you need to monitor 2-hourly potassium. And this table shows the instructions to the dose of KCl added to normal saline depending on the serum potassium levels. Yes, correction of acidosis. The aim is to bicarbonate should rise by 3 millimoles per liter per hour with the treatment. Acidosis usually gets corrected with adequate fluid replacement and insulin therapy. Is there a place for bicarbonate replacement? No. Why? The acidosis may be an adaptive response, and excess bicarbonate causes paradoxical increase in CSF acidosis and may delay the fall in blood ketone levels. Therefore, bicarbonate is routinely not indicated in DKA patients. Yeah, how do you monitor? Blood glucose hourly, blood ketones hourly, and venous blood gas at 1 hour and then 2 hourly for pH, bicarbonate, potassium. And the laboratory plasma electrolytes should be done 4 hourly. And urine ketone is not useful for monitoring of DKA management because the urine is produced, the current value is not giving the current status of the blood. So rest of the management would be fluid management chart, urine catheterization. If patient is not passing urine more than 2 hours, then maintain urine output at 0.5 ml per kg per hour, and consider NG tube if patient is vomiting and comatose, and we need to do pulse oximetry if patient has hypoxia, and you need to monitor vital signs continuously and look for complications of the treatment. And so need to identify and treat for precipitating factors. What are the precipitating factors? Could be infection, acute coronary syndrome, stroke, or lack of insulin. So when you suspect an infection, need to look for the clinical evidence for infection. And remember that elevated WBC may be due to DKA per se, and it does not always suggest infection. And when you suspect infection, start IV broad-spectrum antibiotics depending on the probable focus of infection. And these are the parameters to identify the severity of the DKA. If blood ketone level is more than 6 millimoles per liter, bicarbonate level less than 5, venous arterial blood gas pH less than 7, and hypokalemia at presentation if it is less than 3.5 and GCS less than 12. So in that case, these are suggestive of severe DKA, and resuscitation and treatment should be started without delay, and you need to consider grade 2 care. What are the serious complications of diabetes? Potassium imbalances, hypoglycemia, cerebral edema, pulmonary edema, acute kidney injury, and other rare complications. So these are the few differential diagnoses. Alcoholic ketoacidosis can present just like, and they don't have elevated glucose, beta hydroxybutyrate. They do not have elevated glucose, and beta hydroxybutyrate is the predominant ketone in the body in alcoholic ketosis, and it is not picked up in urine dipstick and need to check blood levels. In starvation ketosis develop over a few days due to lack of insulin, and there will be liposis and ketosis because of this. Yeah. And euglycemic DKA, where plasma glucose is normal in hospital setup. This may be due to partially treated DKA with insulin at home. And in modern era, this is a well-recognized complication of SGLT2 inhibitors. Yeah, how do you manage? As patients, when they present, they have normal glucose level at the start. You have to initiate with 10% glucose straight away with normal saline. And what is the rate of insulin? 0.1 units per hour per kg, and you have to reduce it to 0.05 if glucose is falling rapidly. So when you manage DK in end-stage renal failure, they have lower beta hydroxybutyric concentration, and they have higher glucose and anion gap. They are less dehydrated, and they have high serum tonicity. So their circulatory volume may even high because they're not doing osmotic diuresis. So when you are treating them, may not need fluid replacement. And if they are in hypovolemia, deemed hypovolemia, you may have to give boluses of normal saline or dextrose according to the plasma glucose level. Here, in CKD patients and dialysis patients, the mainstay of treatment is insulin. The rate is 0.1 units, but strongly considered to reduce the dose if the glucose fall is faster or less than 250. Body potassium may be normal as less potassium loss, and usually replacement is not required, and cardiac monitoring and HT is needed if there is high potassium levels. Yes. So what are the metabolic treatment targets in DKA? You have to reduce blood ketone by 0.5 millimoles per liter per hour, increase the venous bicarbonate by 3 millimoles per liter per hour, and reduce capillary blood sugar by 3 millimoles per liter per hour, and maintain potassium between 4 to 5.5. So what are the key messages in DKA? How do you diagnose? 3 criteria, and you need to correct fluid deficit and ketosis, and you need to continue treatment of normal saline, plus or minus 10% dextrose, fixed rate insulin infusion, potassium replacement and monitoring till DK is resolved, and you need to correct precipitating factors, and it usually takes 24 hours. So we'll move on to the second case. The second patient is 70-year-old woman. She was unresponsive since morning, has been unwell for 1 week, generalized weakness and anorexia. And she has had history of diabetes for 25 years. She was on metformin and biphasic insulin. On examination, she was unresponsive. GCS was 9 out of 15. Temperature was normal, and blood pressure was 100/70, and respiratory rate was 16, and saturation was 96. The rest of the examination, including focal neurological signs, were absent. So so we have started her on IVO access was gained and started on 9.9% sodium chloride. Her capillary blood sugar came as high, and urine ketone bodies was nil, and blood sugar analysis showed pH of 7.35 and bicarbonate of 24. So what is the diagnosis? It is hyperglycemic hypoosmolar coma, HHS. So what is seen in HHS? Marked hypovolemia, measured or calculated serum osmolality usually more than 320, marked hyperglycemia, and usually without significant ketone, hyperketonemia without significant acidosis. So these are the differentiating features of DK and HHS. In HHS, hypoosmolar coma, they are usually comatose, they have more hypovolemia, and their sugar is greater than DK, and their ketone is usually less, and pH is normal, bicarbonate is towards normal, and osmolality is more than 320, and usually the resolution, they take up to 72 hours. And remember that mixed picture of HHS and DKA may occur. And differentiating HHS from DK is more problematic in context of severe intercurrent illness due to increased ketosis and non-ketotic metabolic acidosis and in lactic acidosis. So what are the aims of management? I would highlight the differences. Here we talk about the normalizing the osmolality as they have high osmolality, and you need to replace fluid and correct electrolyte imbalances, and it takes the completion takes up to 72 hours, and you need to normalize glucose. And what are the aims of management? The further aims of management: treat precipitating factors, and the prevention thrombosis is important here because these patients are more hypovolemic and they are more viscosity, they have high viscosity, and they are more ill and they have longer stay. And the prevention of foot ulceration is also important. So these are the components of management: IV fluid resuscitation, insulin, potassium replacement, monitoring as in DKA, other than the thromboembolism prevention. So here, how do you replace fluid? It is intravenous when it comes to IV fluids. And there are three questions answered: when, how, and how, when and what and how. And estimated fluid loss is important here. The choice of fluid is again normal saline. Half normal saline is only indicated if osmolality remains high, provided adequate fluid balance is achieved with normal saline. With fluid resuscitation, an initial rise in sodium is expected, but it is not an indication for hypotonic fluid. In 1 liter during the first hour, achieve positive fluid balance of 2 to 3 liters by 6 hours, achieve positive fluid balance of 3 to 6 liters by 12 hours, and remainder during next 12 hours. Once glucose fall less than 250, start 5% or 10% dextrose, 125 ml per hour, and continue with normal saline. So when it comes to insulin, should be started when the blood glucose is no longer falling adequately with IV fluid alone, or immediately if blood ketone is more than 1 millimoles per liter, or urine ketone 2+ or more. And don't start insulin prior to fluid replacement. Why? That would result cardiovascular collapse. You start with low rate of intravenous insulin infusion than DKA. Aim is to fall glucose by 5 millimoles per liter per hour. If the glucose goal is not achieved, look for the adequacy of fluid replacement. If adequate, increase the rate of insulin. End of the 24 hours, keep blood glucose at 10 to 15 millimoles per liter by adjusting insulin infusion rate. So there are differences between HHS and DKA. Usually in HHS, you use lower insulin rate, 0.05, and start insulin only after adequate fluid resuscitation. Yeah, and identify and treat precipitating factors, IV antibiotics if sepsis is suspected. And as already discussed, HHS has increased risk of arterial and venous thromboembolism. Therefore, all patients should receive prophylactic low molecular weight heparin for the full course of admission. And these are the key messages. They have very high blood sugar levels. They are so severely dehydrated. They have high plasma osmolality, and there is no ketosis or acidosis. And the priorities would be gradual reduction of glucose and osmolality, and fluid resuscitation always prior to insulin. And normal insulin is preferred over half normal saline, and insulin lower dose than DKA. Thromboprophylaxis is important and need to correct and treat precipitating factors. And it takes about 72 hours to resolve. Yeah, so we'll move on to the last case. A 65-year-old woman who's disoriented and had abnormal behavior since morning. And she has history of diabetes, hypertension, and ischemic heart disease. She was on metformin, glibenclamide, losartan, aspirin, and atorvastatin. So on examination, she was verbally communicating, even though she was confused and disoriented. GCS was 14 out of 15. She has not had fever, blood pressure was normal, and saturation was normal. No other focal neurological signs except confusion. So what is the most appropriate immediate step in management in this patient? Yeah, so patient is a non-diabetic patient coming with disorientation. Could this be hypoglycemia? Yes. So you check capillary blood sugar level. So it came as 55 milligrams per deciliter. So what is the most appropriate initial management? So there are 5 options. Are we going to give intravenous, or are you going to go oral? If it is intravenous, is it 5%, 10%, 25%, or 55%? Yes. Yeah, the answer is 25% dextrose, 75 ml orally. Why do I select oral dextrose? Yeah, we'll discuss in the coming slides. Yes. So what is hypoglycemia? Hypoglycemia is when blood sugar level is less than 4 millimoles per liter. We call it when it is less than 70 milligrams per deciliter. Yeah. So as always, there are 3 main questions to be answered: when, what, and how to treat. So soon after the hypoglycemia is detected, you need to treat. How do you treat? If patient is conscious, cooperative, and able to swallow. If all those 3 criteria are there, then you can treat them with oral glucose. What is the dose? It's 25% dextrose, 75 ml. If patient is unconscious, not cooperative, unable to swallow, or if they cannot take anything orally, if they are keeping them nil by mouth, then if any of those features are there, then you have to give IV glucose. How do you give? 25% dextrose, 75 ml, or 10% dextrose, 150 to 200 ml over 15 minutes. So if you have selected oral arm, then you can give 3 cycles. Every time once you give 25% dextrose, 75 ml, you check the glucose level after 10 to 15 minutes. Then look for the glucose level, whether it has gone up more than 70 millimoles per liter. If not, then you have to repeat it 3 times. If it is not correcting with oral glucose, then you may have to shift to the IV glucose. Again, the same dose. Yes, once hypo is recovered, if patient can take orally, give a normal meal like glass of milk, and they can take that orally. If you need to keep them nil by mouth, in that case, you can go by, you need to continue them with 10% glucose, 100 ml per hour intravenously. If patient was on IV insulin before patient getting hypoglycemic attack, then you may have to restart IV insulin with IV 10% glucose. But the rate of IV insulin can be adjusted according to the continuous monitoring of glucose level. Yeah. So what are the key messages in hypoglycemia? So you can give glucose oral or intravenously. It depends on the ability to swallow and other features, whether they are cooperative, whether they are conscious. Even though they are confused, if they are conscious, if they are cooperative, then you can give them oral. Then if IV, when you are giving IV, you try to give IV to large bore cannula via large vein. And you do not use 50% dextrose intravenously. Why? It is highly irritant and it is difficult to give. Don't give 50% dextrose intravenously. And regular CBS monitoring for 24 to 48 hours is recommended. And if patient is on insulin, don't omit next dose. You have to review the dose and continue with insulin regime. If patient was on sulfonylurea, review the drug regime. In our patient, she was 65 years of age and she was on glibenclamide. Therefore, you have to substitute the long-acting drugs with short-acting drugs. Yeah, these are my references. I used 2021 and 2022 NIMS guidelines, JBDS IP guidelines. Thank you very much.
Thank you very much, Suranga, for that excellent lecture and perfect timing. And you sound, you made everything so easy for us. So there are a few questions, I think. One person is asking whether we can give KCl after 1 liter of normal saline without checking the potassium level.
No, usually we check potassium levels at the outset, we check if potassium level is less than 3.5, you have to replace with potassium at the with very high dose. If it is between 3.5 to 5, then with 40 millimoles per liter. If it is less than 3.5, you may have to give more potassium depending on the value. And usually already you have checked, and from the second pint onwards, you have to add KCl.
So basically, we have to check the potassium after 1 liter of normal saline. That's what you say.
No, if it is the initial one, if it is less than 3.5, you have to keep on checking. If it is within the normal range, then you have to add potassium from the second liter. The first liter you can give liberally. If potassium is normal, you can give liberally first liter. Then from the second liter onwards, you have to add potassium depending on the initial value.
And they are asking when to start normal insulin or oral drugs in DKA.
Sorry?
When to start normal insulin or oral drugs in DKA? I think it's little beyond your talk though.
Yeah, I think I have mentioned that if in type 1 diabetes, you give intravenous IV, the insulin, you have insulin subcutaneous to be started for each and every patient who develop DKA. And for type 2 patients, if they are hospitalized, then you may have to, depending on the situation, you have to decide whether to give insulin.
Indications for bicarbonate in DKA.
I nicely discussed that with a good slide, and I explained it very well, because there is no indication for bicarbonate in routine management of DKA.
There's one last question. DKA later phase, if ketones become negative, but acidosis persists, how should we manage?
Yeah, that could be due to hyperchloremic acidosis. If you have given a lot of normal saline to that patient, they can have hyperchloremic acidosis due to excess fluid, excess normal saline. So the management is different. Yeah.
So that's all for the questions. I think we shall move on to the next speaker. Over to you, Dr. Ganaka Senaratne.
Thank you.
Right, thank you, Suranga, for that wonderful talk on diabetic emergencies. So please accept our certificate of appreciation, which will be sent as an email. Right, this is it. So thank you so much, Suranga, again, for making our life so easy by giving this wonderful talk. Right, so let's move to the third talk of the day. That will be on approach to transient loss of consciousness by Dr. Anoja Rajapaksa. Dr. Anoja has graduated from University of Colombo and certified as a specialist in general medicine by the BGIM, University of Colombo, and also certified as a specialist in geriatric medicine in UK. And she's trained at Mersey Deanery, United Kingdom. Formerly consultant in geriatric medicine and stroke medicine at Sherwood Forest NHS Trust. Currently, she's working in private sector at Colombo, and she's a fellow of Ceylon College of Physicians, fellow of American College of Physicians, and fellow of Royal College of Physicians, London and Edinburgh. And she's involved in a lot of postgraduate teaching and research activities with an H index of 30. And she's one of our SLSIM Council members as well. So may I invite cordially to Dr. Anoja Rajapaksa to deliver her talk on approach to transient loss of consciousness. Audio, Anoja.
Thank you, Ganaka. Good afternoon. Thank you for the opportunity to talk. I thank both colleges for this opportunity to talk to you about approach to transient loss of consciousness. This is a very common situation, affects up to about 50% of the population, especially geriatric patients. If you go into their history in detail, you might find out some of them have actually had episodes of transient loss of consciousness. They don't come forth with the information, some due to cognitive issues, others because they are too embarrassed about the fall and they just want to brush it off saying, oh, it is nothing. All patients who come to me with a fall, I do ask them about the details of the fall. I do ask them whether they remember slipping on something, tripping on something, whether they remember putting their hands out, defending the fall, whether they remember their face coming and touching the surface or the floor, and whether they remember asking for help. If I have an eyewitness, I ask them whether they saw the patient trying to prevent this fall. If any of these information is not available, I consider that this patient has probably had a transient loss of consciousness for a very brief time. Spontaneous loss of, the definition of transient loss of consciousness is spontaneous loss of consciousness with complete recovery. I repeat, there has to be full recovery of consciousness without any neurological deficits. This is the same thing that we call as blackouts, fainting episodes. Some people loosely call it collapses, but this definition covers only patients who have had episodes of loss of consciousness with the collapse. The initial assessment is very important because as time goes, patients forget the details and we lose vital information. We need to find out the circumstance of the event. Did it happen while they were exercising, after finishing exercising, during nutrition, after a heavy carbohydrate diet? Was there dizziness, palpitations immediately before the fall? The posture immediately before the event, was the patient standing? Were they lying in bed? Were they seated? The appearance of the event. If somebody saw the patient fall, were the eyes closed? Were the eyes open? Were the eyes rolled up? Did they look pale like a sheet or was the face flushed? Did they notice any movements in the limbs or were there any laryngeal spasms? If they have sustained any injuries, site of the injury and the severity. If we fall with a simple faint or neurocardiogenic syncope, due to gravity, the tongue comes out and more likely the patient will have a bite in the tip of the tongue. If it is due to a seizure because of the laryngeal spasms, they are more likely to have a bite on the side of the tongue. Ask the patient the duration of the event from the onset to the full recovery. Was there any weakness on one side of the body and for the duration? Was there post-event headaches, drowsiness noted? Get details about the medical history. Is there a history of structural heart diseases like congenital heart disease, acquired valvular heart disease, ischemic heart disease, myocardial infarction, CABG, cardiac stenting, pacemakers in situ? Neurological conditions like seizures, Parkinson's disease, stroke, autonomic dysfunctions. Orthostatic hypotension contributing causes like diabetes, whether the patient was intoxicated with alcohol or whether they were taking any medications like antiarrhythmics, antihypertensives, diuretics, antifungals, macrolides, fluoroquinolone, which can increase change of QT value. Go into the family history, ask whether there is a history of sudden death in their family, especially people below the age of 40 years. Any family history of cardiomyopathies like hypertrophic cardiomyopathy, etiogenic right ventricular cardiomyopathy, channelopathies like QT, long QT syndrome, short QT syndrome, Brugada syndrome, familial reflex syncopes, migraine headaches. When we go to the examination, check the blood pressure on both arms. A significant difference in the blood pressure in the two arms may be due to aortic dissection or in a younger person, aortic coarctation. Do the postural blood pressure. A significant drop may be due to a massive internal blood loss like in GI bleed, ruptured ectopic, ruptured ovarian cyst, ruptured spleen, or a leaking aortic aneurysm. Note the pulse rate and the rhythm because this could be a cardiac syncope. Listen to the heart, look for aortic stenotic murmurs or evidence of atrial myxomas. Listen for signs of heart failure. Get the respiratory rate, oxygen saturation, because this collapse could have been because of a pulmonary embolism or anxiety. Do a quick neurological examination, look at the size of the pupils, whether there is any obvious weakness, because this could be a subarachnoid hemorrhage or a seizure. If the patient has any of the 3 Ps, that if they had a posture, a long-standing posture, or if they had any provoking factors like pain, sudden, unexpected, unpleasant sights, smells or sounds, cough, micturition, if this happened during a meal or postprandial, after exercise, or there was prodromal symptoms like nausea, vomiting, perioral numbness, this could be a simple faint. During a simple, uncomplicated faint or a syncope, also there can be brief seizure activity. It is very easy to diagnose. This patient has been, most probably this man has been standing for a long time, so this is a simple faint. Some of you might remember this picture that was circulating in the internet about a man who had who collapsed while jogging and was resuscitated and was admitted to NHSL. We were wondering whether this man fell backwards, forwards, or sidewards. This is not relevant. If somebody has a transient loss of consciousness while exerting any form of exercises, that's considered as cardiac syncope until proven otherwise. These people need further investigations. They need the basic 12-lead ECG. We should be looking for a sinus bradycardia, sinus pulses. We should be looking for heart blocks, type grade 2 or grade 3. We need to look for alternating right and left bundle branch blocks, ventricular tachycardias, supraventricular tachycardias, atrial flutters, atrial fibrillations with rapid ventricular rates. Calculate the QT interval, see whether it's prolonged or short. Look for ST segment abnormalities. Look for T-wave abnormalities, which can be seen with some cardiomyopathies. Odyssey score is a score that we geriatricians like, because this we can do it at the end of our consultation. We score 1 point for the age, if they have a cardiovascular risk, if there was syncope without any prodrome, and abnormal ECG. Higher the score, higher the mortality. This is not the only scoring system we have. We have EDC score, but this actually tells us whether it's a cardiac syncope or not. We have the Canadian syncope risk score. Here, we need lab tests like the troponin and BMP to interpret. Faint score is a new one, but it is still not internationally validated. When we go to investigations in a patient whom we think is scoring high on our scoring system, we need it. If we hear a murmur or not, we need to do a thoracic echocardiogram. We should look for aortic stenosis and get an idea about the degree of stenosis. As we know, the critical stenosis can present like with syncopal attacks. If there were signs of heart failure, echo is important. If there's a family history of sudden cardiac death, echo is important. If the ECG was normal, we should do an ambulatory ECG monitor at least for 48 hours. If it is infrequent and recurrent, we might have to put an implantable loop recorder to catch an event when this event that causes transient loss of consciousness. If you are doing a test, if the patient was exercising and if everything has been normal, we might have to do a stress ECG to look for the arrhythmia. Other test is a tilt table testing. If all the cardiac investigations are normal and if we think it is not a non-cardiac, but it is significant, we need to do serum electrolytes. Serum hyponatremia can come with seizures, calcium levels, magnesium levels. If you are thinking of pulmonary embolism at the end of our examination, arterial blood gas, D-dimer, pregnancy test, pelvic ultrasound scan if you're thinking of a ruptured ectopic or ruptured ovarian cyst, EEG, late onset epilepsy should have a brain imaging, ideally a MRI. This is a This is a 75-year-old patient who was admitted with a large right-sided MCA infarct. She was not thrombolyzed. She developed malignant MCA syndrome and had hemicraniotomy. She was recovering well in her rehabilitation when she started developing episodes of transient loss of consciousness. These episodes were very similar to each other. It usually happens after about half an hour into a physiotherapy sessions. Patient is noted to be pale and she recovers completely when put supine. We have noted her blood pressure to be low on all occasions. ECG was normal. We had done a Holter monitor. Echocardiogram was normal. And this was due to orthostatic hypotension. We had some interventions like bum squeeze or squeeze, gluteal muscle squeeze, which allowed her to continue her physiotherapy sessions without having these sessions afterwards. This is a 54-year-old man who was admitted to Navaloka Hospital with acute stroke. He was thrombolyzed and made a good recovery. After about 6 months down the line, I got a call one day saying that the man was watching TV and he has gone unconscious, and they said he's perfectly well now. But when I went into details, I realized he had had a seizure, and this was a post-stroke seizure. Upright tilt table test is not the gold standard of diagnosing the cause. Why I say that is it's very difficult to simulate what happens in the normal circumstance inside a lab. But we try. The indications are recurrent transient loss of consciousness with unknown cause, to differentiate a convulsive syncope from epilepsy, to see patients with syncope with bradyarrhythmias to assess suitability for pacing. And even if it's a single episode of transient loss of consciousness, if it's a high-risk patient like a bus driver or a pilot, we tend to do this investigation. There are contraindications. We do not do it in pregnant females. We do not do in heart disease. We do not do in TIA and stroke because drop in blood pressure can be detrimental to the patient. This is usually done in the electrophysiology lab or a quiet room with full resuscitation facilities. We need a bed which can be raised to 70 degrees and put to supine, usually motorized one, because if the patient is symptomatic, we need to put them flat as soon as possible. We need a footboard to prevent the patient from falling. When the patient comes with investigations, we explain everything what is going to happen, put a cannula, put a blood pressure monitor, do a ECG, and allow them to rest for about 20 minutes. The passive test, we do it for 20 minutes. If we get the episode, if you can, it is diagnostic. If you don't, we try to do a provocation test. Usually we use GTN 2 sprays. Continue it for another 10 minutes. And usually the whole procedure will take about 1 hour. Throughout the procedure, we do the ECG, we do the blood pressure, we monitor the symptoms. This has to be interpreted carefully because sometimes we find things but not corresponding symptoms. If we get the symptoms and the expected findings on the tilt table, well and good, that's a positive test. Otherwise, patient might get symptoms and we might not have the desired effects on the test, which could be due to psychological reasons or if the patient is malingering the effect. We monitor the heart rate and blood pressure throughout. Normally, when we stand up, the blood pressure remains stable, the heart rate goes up and normalizes. In type 2 neurocardiogenic type, or the normal fainting attacks we call about, their blood pressure falls, their pulse falls, you get the symptoms here and then they recover. Type 2 is cardio-inhibitory type, where you have a fall in heart rate before the fall in blood pressure. This is again divided into type A and type B. Type A is for patients who have a pause which is less than 3 seconds. Type B is the pause more than 3 seconds. Vasodepressive type, there is a fall in blood pressure, usually below 80 millimeters. Usually when the blood pressure falls, if the heart rate goes up, it is postural orthostatic hypotension. If the blood pressure goes down, but the heart rate does not go up as expected, it is due to dysautonomic symptoms. Carotid sinus hypersensitivity is a reflex-mediated variant of vasosyncope, usually due to pressure on the carotid sinus, causing bradycardia and hypotension. This can be due to a tight collar, shaving, turning the head, or tumors. You can elicit in the history. If you're very confident, you can do a cardiac massage, but there's not enough evidence to recommend this. I personally wouldn't do it because we know listening to the carotid artery is not good enough. The bruit is not corresponding with the degree of stenosis the person is having. Therefore, if you are doing it, I advise you to have a carotid Doppler scan beforehand. Our duty to the patient doesn't end at this. We need to, if it's a driver or a cyclist, we have to tell them not to drive or not to cycle until we establish the cause. Once we establish the cause, we should advise accordingly. We should find out what his job is. If it's a high-risk job or like a manual worker who is climbing on scaffoldings, we should tell them to stay away from climbing heights until we come to a diagnosis. We also need to ensure that the other people are safe as well, especially if it is a bus driver or a heavy goods driver or a pilot. They should not drive, and we should encourage them to talk to their employer and not engage in their jobs until we have a diagnosis. Thank you.
Thank you very much, Anuja, for that elucidative lecture. Actually, you made that confusing topic very easy for us. At the moment, there are no questions. Yet, I would like to ask a question with regard to this. You said that we will give GTN sprays to provoke the situation in a tilt table. So, are there any sort of when you are performing that, are there any problems by doing that? Just have you encountered anything?
We don't do it in high-risk patients. If they have ischemic heart disease and all, I will be very, very careful because I don't want to drop their blood pressure. But if it is high risk, they have gone through the test for about half an hour already, and I don't want to conclude. So there is no problem in safe situations. And you have a motorized bed where you can put them flat and you have the normal sail and rib going. It's not risky, but that experience will be unpleasant. So I don't want to precipitate MI. So I won't try in high-risk patients. Others, there is no problem in doing that.
There's a question. What is the cost of the tilt table test in the private sector?
It's done at Navaloka by the electrophysiologist. I didn't find out that. I'm sorry. It's done in government sector at NHSL.
Yeah. Can you explain the site of the tongue bite associated with the particular cause?
So what they say is, if it's a normal fall, you fall forwards and then your tongue comes out due to gravity. So you bite the front of the tongue. If it is due to a seizure, there's laryngeal spasms going on, so the tongue stays in. So during the recovery phase, we put the patient to a side or not, so they tend to bite the side of the tongue. Not the tip is usually protected. That's what the literature says.
Yeah, I think that's those are only questions that we have received. Yeah, Ganaka, it's over to you to introduce our next speaker.
Thank you.
Right, Anuja, thank you so much for your wonderful talk on assessment of transient loss of consciousness. Please accept our certificate of appreciation, which will be sent as an email to you. That is what we displayed in this stream. Thank you.
Thank you, Ganaka.
Final talk of the day that will be on neutropenic sepsis, preventing an avoidable tragedy. So this particular talk will be done by Dr. Priyamali Jayasekara. Priyamali is a senior lecturer and honorable consultant and specialist in medicine at US University. She has obtained her MBBS from University of 2020, and she obtained her MRCP UK 2010 and followed by fellowships from both colleges, London and Edinburgh, and then fellowship from American College of Physicians as well. And then she obtained her MRCP. She is our treasurer right now in College of Internal Medicine. She's been a member of council member of CCP some time ago and a council member of Pediatric Medicine as well. So may I invite Priyamali for her lecture on neutropenic sepsis, preventing an avoidable tragedy. Over to you, Priyamali.
Thank you very much, Ganaka, for that kind words of introduction. At the outset, I would like to thank Professor Arosha Disanayak, President, Ceylon College of Physicians, and Dr. Ganaka Seraratna, President, Sri Lanka College of Internal Medicine, and Dr. Madhwat Hetteraj to coordinating this and giving me this opportunity. So I will be taking through neutropenic sepsis, preventing an avoidable tragedy. So we'll be discussing few case scenarios and the definition, approach, and management, mainly the antibiotics. So starting with the case history, it's a 56-year-old female presented with confusion and fever for 1 day. On examination, temperature 38, pulse rate 110, tachycardia, blood pressure 110/70, respiratory rate 22, and rest of the examination normal. So further history, she is on neoadjuvant chemotherapy for carcinoma of breast and had her 4th dose of chemo a week ago. So whenever this kind of patient comes, this cue so far comes to our mind. So my patient, she was not hypertensive, but it was 110/70. She had altered level of consciousness. She was tachypneic. So she had 2 out of 3 out of this hat. So we have to send urgent investigations like blood cultures, urine culture, and full blood count and CRP. So in first hour of admission, we started her on IV fluids, 10 ml per kg bolus. You might wonder, why did I start when the blood pressure is normal? But patient was tachycardic and impending shock, so she was started that, and she was started on empiric antibiotics, which is piperacillin tazobactam infusion. So we have stabilized the patient, sent to the ward. Then 2 hours later, only the full blood count arrived. That is the usual happening. It was white cells were 1.1 and absolute neutrophil count is 440. So we'll see whether I have done correct management when I'm going through. So starting with the definition of neutropenic sepsis, a neutrophil count of either less than 0.5 or less than 1 and falling, or with a temperature of 38 Celsius on one occasion, or 37.5 for 1 hour, or it is less than 36, which is hypothermic, or any other signs and symptoms consistent with clinically significant sepsis we call as neutropenic sepsis. And who will be neutropenic? So neutropenia can be occur in patients undergoing systemic anti-cancer therapy and patients undergoing immunosuppressive treatment for other conditions such as rheumatological conditions, hematological conditions and conditions such as congenital neutropenia, and it is an emergency. So this all my talk based on the up-to-date, which is giving the latest account of this, and then the NICE guidelines regarding neutropenic sepsis, and there's another guideline which is relevant to the oncology patient because maybe they are the people who undergo neutropenic sepsis, infectious disease working party, and intensive care working party of the German Society of Hematology and Medical Oncology. And with the empirical and prophylactic use of antimicrobial guidelines published by College of Microbiologists, liaising with the other colleges, that was in 2016. And I have gone through few NHS trust guidelines. So whatever it is, what they say is you have to take the history. It doesn't mean that you have to take 5 minutes or 10 minutes to take history. It will be a short targeted history within a minute or a two. And just see your patient, has the patient had chemotherapy last 6 weeks? If there are another reason for neutropenia like methotrexate as treatment for a rheumatological condition, has the patient been treated with prophylactic antibiotics? Whether the patient is systemically unwell? As I have already explained, like fever 38 Celsius or a 37.5, or patient is hypothermic, and any other like symptoms such as evidence of infection, sore throat, cough, dysuria, cellulitis, or the meningitis or encephalitis symptoms, hypotensive or tachycardia. So, you know, whenever the patient comes, we do observations. So what are the things we give observations? They are the blood pressure, pulse, temperature, respiratory rate, oxygen sats, and then there is something called news. All of you may have heard, some may be using in their emergency departments, and it is just the same thing we are tabulating, and it is your life is much easy when you know what is the risk of these patients. So it is actually one of the prognostic triage tool for septic patients. So you can use that to see the severity, or if just you can just go through your queue so far. So once the patient comes, you do this history examination. The investigations are the urgent bloods, including full blood count, guanese, creatinine, and the CRP, the basic stuff, and the blood culture, mainly from the peripheral side, peripheral line, and if central line is present, we have to take it from the central line as well. And the blood gas, especially if patient is hypoxic. So the main thing you have to remember is do not wait for full blood count results before giving intravenous antibiotics. So we have to follow the sepsis 6 guideline. So what is it? It's very easy to remember. 3 to take, 3 to give. The 3 to take are just to take the blood cultures, serial lactate, and the urine output. So, and we 3 to give oxygen, IV antibiotics, IV fluid. It's a simple our sepsis management. And now coming back to the rest of the examination after your usual observations, do the full clinical examination including mouth, chest, perineum, line sites, skin and fundi. And assess clinically for meningitis or encephalitis such as Kernig signs, neck stiffness, and take swabs from the appropriate inflamed sites. What are the other investigations? We have sent our basic tests including cultures. So we can send midstream urine, the full report, and if stool cultures, if the patient is having diarrhea, can check for C. diff, but it's not readily available with us. And if you are not sure whether this vesical fluid is a herpes infection or whatever, you can send a serology and aspergillus tests. And if indicated to do the chest X-ray, relevant X-rays. And just check the previous microbiology results because these patients used to undergo similar kind of infections time to time. So whether they are previously colonized with infected with MRSA or ESBL. So in that case, we may have to get microbiologists, discuss with microbiologists to start which one to start, which antibiotic to start. So assume all these neutropenic sepsis patient as neutropenic sepsis and treat accordingly until proven otherwise. And I have mentioned this same thing, this highlighted one in the previous one as well. So do not delay administration to wait for blood results before giving the initial dose of antibiotics. And the most important part of this talk is regarding the antibiotics. Usually antibiotics should be given within 1 hour. And it's a first line therapy is usually intravenous piperacillin with tazobactam. And we have to give it within 10 minutes of prescribing that particular antibiotic. So the patient has to come to the wherever the medical casualty or A&E or a wildfire found in the ward. And once we decide, we have to give it within, nurses should give the antibiotic within 10 minutes. And if the neutropenia confirms, we can continue same antibiotic 6 hourly. If patient is not neutropenic, but still if we think patient need antibiotic and running fever, so it can be given as a 3 times a day injection. So some guidelines, and especially the Sri Lankan guidelines, say we can add, if we wish, it's like what they say is plus or minus, we can add amikacin. So what is the second line therapy? If the patient is having history of non-life-threatening penicillin allergy, so the second line is meropenem 1 gram TDS instead of piperacillin tazobactam. And if there's an allergy to penicillin, so you can't give those, so it is ciprofloxacin 400 BD. And if you need additional antimicrobial cover, like if we think of gram-positive organism, then you may have to add teicoplanin. So antifungal treatment. So we are not going to start antifungal at the when the patient comes to us, and we may have to wait for 4 to 6 days. And any signs or symptoms of diarrhea, mucositis, perineal or abdominal infection, so we add metronidazole. And if there are herpetic infection, yes, acyclovir, IV or orally. And the main important thing is like antibiotics should not be switched simply due to persistent fever. So you have to change according to the clinical deterioration of the patient. Just fever doesn't mean that you have to change that antibiotic. And look at the positive cultures and then adjust or sensitivities, and you can adjust the antibiotic later. And to decide whether to switch to oral antibiotic therapy, so it depends on various factors, including the clinical response, infective source, and individual patient risk. I will be talking in a few minutes. So you have done whatever the treatment, so you will reassess the patient in 48 hours. And if the patient is afebrile at 48 hours, if we couldn't find the cause, but low risk, so we may consider change to oral antibiotics. If the persistent fever at 48 hours, so reassess daily with repeat. You may have seen 3 repeats: repeat of history taking, repeat examination, repeat investigations. And then if there's no change, patient remains febrile but looks well, you may continue the antibiotics. But what they suggest is if we have already started aminoglycoside, better to stop that within 48 hours. So if our patient is deteriorating, so we rotate the antibiotics. So as example, piperacillin tazobactam to meropenem. And consider adding vancomycin if there's evidence of line infection or a mucositis. And still febrile at day 4 to 6, then only we are investigating this patient to fungal infections. So these guidelines are important because now we are also in a resource poor setting. So we know when to start these investigations. So then we do the HRCTs and the rest of the investigation to see whether this particular patient is having any fungal infection. So if the radiology is negative, so we may have to review the patient again to see any sources of other sources of fever. And if there's evidence of fungal infection clinically or biochemically or with any other microbiology results, so we may have to start antifungals. Usually we start voriconazole or either amphotericin, so we may have to discuss with the microbiologist. So these are the risk factors for systemic fungal infection. So our particular patient is having this risk factor. So we have to think of adding the antifungals in day 4 or 5. So the patient who had prolonged neutropenia, or corticosteroid therapy, altered bacterial flora, so breakdown of mucosal barriers and building, that means the patient has exposed to some fungal spores. Or the highest risk patient is the one who had a neutropenia longer than 14 days, or the following induction chemotherapy for leukemia, or the intermediate dose of melphalan, that kind of drugs. So they are high risk to get the antifungal. They are high risk to get the fungal infection, so we may need to start them on antifungals. So how do we decide how long we are going to give this antibiotic? So we started antibiotic on our neutropenic patient. If the neutrophil count is rising above 500, so we may have to review and stop antibiotic if the patient is apyrexial for 3 days. If these criteria are fulfilled, like cultures indicate no organisms eradicated, all site of infection have resolved, patient free of signs and symptoms, and falling acute phase reactor like CRP. So if the patient fulfilling these criteria, then we can stop the IV antibiotic in 3 days. Imagine still the neutrophil count is less than 500, but patient is low risk. But the above 4 criteria I have discussed are there, so we may have to stop the antibiotics. And if the patient, like when patient has been afebrile for 5 days. If patient is high risk, so we may have to continue this for 10 days or more, or until neutrophil count is rising above 500. So now I have been talking about the oral antibiotics, because at the end of the talk, I will be telling about this oral antibiotic again. So there are some low risk patients. In that patient, we might start them on oral antibiotics. So the preferable oral antibiotics are ciprofloxacin. It's not the 500 BD, it is 750 BD, and the coamoxiclav. We can start levofloxacin, either clindamycin, depending on the infection we are thinking of. So if we want to treat this patient as outpatient, so it is actually clinician decision after considering all these facts, the neutrophils, looking at the patient's parameters, and the patient's individual things like whether the patient is mentally competent patient, living near the hospital, whether the patient has all the facilities and all. And this is what we were talking about. Can we send them home? So if we have to send them home, apart from our clinical parameters, different people look at the patient differently. So their experience is different. So I can't just say in my experience, I can send that patient. So we need some guidelines. So these are the guidelines kind of things. They have made scores, like it scores MASCC risk. It is the kind of multinational association of for that cancer care, systemic cancer care risk. And there's a calculation, so we can put our patient data and see this calculation. In particular calculation, if the score is higher, less risk. And there's another calculation which is called clinical index of stable febrile neutropenia. There is the other way around. If the count is high, they are high risk. So either this or that. If we don't have good confidence of sending this patient home, we can decide on putting to these things and see whether our patient is eligible to go home after a few days. And the controversial point is whether we are giving the granulocyte colony stimulating factor for neutropenic sepsis. There are a lot of trials been there and nothing is convincing. What they say is, according to the current guidelines, they are used when the risk for febrile neutropenia is about more than 20%. And it is approved for the neutropenia associated with stem cell transplantation. Then, so what they say, they do not recommend the routine additional use of GM-CSF to standard treatment of sepsis or septic shock patient with neutropenia. So what they say is, it may be used for both prophylaxis and treatment of neutropenia to reduce the risk of neutropenic sepsis. So it's maybe. So looking at the patient condition and the availability of the things, we can decide, but there's no hard and fast rule that we have to use cornerstone factors. Another thing, so I have been talking all the things about the antibiotic and that, but what about the fluid therapy, vasoactive medications, anticoagulants, mechanical ventilation, glucose control, or renal replacement therapy? So what they say is there's no evidence that sepsis and septic shock in patients with neutropenia need to be treated differently to non-neutropenic patients. So it is as all the other septic patients. And I think everyone may have gone through the recent septic guideline, and this I will put only one slide. This is the latest regarding the vasoactive medication. So we have been doing it long time, peripheral, using vasopressors peripheral lines. Now it is in the guidelines, keeping the mean arterial pressure of 65. As usual, we start noradrenaline first, then we can start vasopressin. If the patient has any cardiac condition, it is the dobutamine is the choice. So the corticosteroid then RBC. So the continuation of corticosteroid therapies evaluate individual patients. So there's no hard and fast rule to start or stop. And the blood transfusion only if the hemoglobin is below 7 with the risk factors such as myocardial infarction, any other ischemia, hypoxia kind of thing. And if the patient's hemoglobin is above 7, should not recommend blood transfusion. And the nutrition, it is the recommended one is enteral nutrition than parenteral nutrition. And the calorie requirement calculation is as septic patients. So certain conditions like neutropenic enterocolitis, several viral or bacterial gastrointestinal infections, gastrointestinal graft versus host disease, it is, we have to be like post, or at least we have to use with caution, or we may have not use the enteral nutrition. So the setting goals of care. It is neutropenic septic patient also benefited from timely and targeted therapy. That is why we asked to start that immediate things. And treatment goals, we have to discuss with the patient and the family. And typically full code management, that means without limitation of ICU resources applied to patients with this like curative therapeutic options and those in remission of their malignancy, as well as to patients in whom cure is not likely, but the expected lifespan is substantial. So all these patients deserve this proper full ICU care. So then do we overtreat patients with neutropenic sepsis? We may, don't know. What they say is, it seems likely that many low-risk neutropenic cancer patients with solid tumors, so it's mind you, it's a solid tumors could be managed as effectively and as safely with shorter courses of antibiotic with oral rather than intravenous antibiotic as outpatient rather than inpatient. So, but that is why these scores, which I have already discussed, they are, and but I think with all these evidence-based guidelines and we always have to take the patient side. We have to treat the patient and neutropenic sepsis initially. Then leisurely we can decide, can we send this patient home? So I'm finishing with this case history. This is a patient encountered by us. It's a 69-year-old woman who presented with the medical casualty with 5 days history of sore throat and dysphagia. And in day 3, she developed diarrhea and right iliac fossa pain. So it's past medical history of hypertension, chronic kidney disease, recently diagnosed seropositive rheumatoid arthritis. Patient is on prednisone 10 mg daily, methotrexate 12.5 mg once a week, and folic acid daily. And patient had taken a single dose of methotrexate. So prior to this presentation, she had occasionally taken NSAID for her joint pains. On examination, BMI 17, patient is pale, anicteric. She had severe mucositis with oral candidiasis. And she is febrile, non-lymphadenopathy. Abdomen distended with rebound tenderness, with RIF tenderness, with absent bowel sounds, with the empty rectum in rectal examination. So her blood pressure being 100/70, she's tachycardic, respiratory and nervous system unremarkable. She had joint deformities. So we ran some tests. The white cells, you can see white cells, and the absolute neutrophil count is 390, and CRP is 146. The creatinine is slightly elevated. And this patient, fluid resuscitation done, and commenced IV meropenem 500 gram TDS, 500 milligram TDS. So you might ask, why did I start meropenem, then teicoplanin, then tazocine, piperacillin tazobactam? So it's the second line, but whatever the available, best antibiotic you have to start, so patient was started on that, and barrier nursing care was provided. And patient ultrasound scan showed just dilated bowel loops. As usual, they can't comment on bowels. So this is the patient's CT scan abdomen. This is non-contrast. So you can see the first CT. It is multiple dilated and general bowel loops. And the second one is this diffuse edema of the wall, cecum, and ascending colon. So what is the diagnosis? So it is neutropenic enterocolitis. So patient was in neutropenic sepsis, and we managed to save patient life by acting promptly. So this was published in Asian Journal of Internal Medicine. So the key messages I want to give: the symptoms of neutropenic sepsis may be minimal. So neutropenic sepsis carries significant morbidity and mortality. Empirical antibiotics should be commenced with 1 hour of admission. Administration of antibiotics should not be delayed to wait for confirmation of neutropenia. Thank you.
Thank you very much, Priyamali, for that excellent lecture and taking us through to an area which was very neglected. Actually, we have not spoken about neutropenic sepsis for quite some time now. And there are a few questions. Let me go to them. What is the reason to choose PIP-TAZ as the first-line antibiotic?
Actually, it is guideline-based. I think according to the trial studies done so far, not in only our country, it's a nice guidelines. Even the up-to-date says that it's a broad-spectrum antibiotic which have a bit of a both, mainly the positive cover, but it has negative cover as well. But some trust, they asked to add aminoglycoside or amikacin as well as others. I think being a broad-spectrum antibiotic is the reason people has to select their meropenem.
I also have a question, just want to ask, what does our guidelines say? Do we have Sri Lankan guidelines for this?
Separate guidelines recently published. There's a guideline for cancer patients. There's a pediatric ones, but for the guidelines published in 2016 about antibiotics, what they say is also start on piperacillin tazobactam, and either if you like, we can add amikacin or not. Or the second line, they asked to add aminoglycoside. But most trust in the other countries, they discourage aminoglycosides.
The next question is, do you need to start at low dose, renal dose, when they have sepsis-induced AKI? What is the recommendation?
So when the patient comes to us, we have no idea whether the patient is in sepsis in AKI or not. So its recommendation is to start the full normal dose of antibiotic. But if you know this patient is already a known patient who had chronic kidney disease or potential AKI with, according to the history, no urine output kind of, you can start the half dose. Yes, I mean, you can start with the dose, then you can reduce the frequency.
Can one develop neutropenia with a single dose of methotrexate?
Yes, that was very rare incident. Still, they can develop neutropenia with a single dose, as well as people can develop neutropenia even in carbamazole single dose. That is very rare, but that is why it was published as a rare incident.
What are your thoughts on flucloxacillin and Genta in low resource setting as the initial treatment?
Flucloxacillin has a positive cover mainly. So if we are suspecting Lyme sepsis, still they recommend vancomycin than flucloxacillin in the guidelines. So the other one is there's a gentamicin.
Yeah.
So gentamicin also in our guideline they set as a second generation, but because of the renal toxicity, most of the UK trust they are not recommending aminoglycoside. Even we start, they want to stop the antibiotic after 48 hours aminoglycoside mainly. So I think better to go for vancomycin than flucloxacillin.
Is GMCSF available in Sri Lankan hospital?
Yes, it is available. It is ready. Don't know these days, but it is available, and most of the time oncologists giving it as a prophylaxis as well before giving the chemotherapy and to prevent this neutropenia.
At what point will you start vasopressin on a patient on noradrenaline in septic shock? That's
So
irrelevant to your talk. Yeah.
It depends. We start noradrenaline on a patient and we go by the blood pressure. If it is not coming up with certain rather maximum doses when it's coming up, better we add to the vasopressin. So there's no hard and fast rule. You start this one and wait this time and all. Sometimes you may start both together within 10 minutes interval. It depends on the patient's condition.
There are one or two questions. I'm not sure about the time limits. So I think we are. Shall we ask this question also from you? What's the place of GCSF in the presence of neutropenic sepsis with underlying bone marrow malignancy?
So, guidelines say you may or you may not use, but only stem cell transplant has undergone, then they recommend. But if the patient, there's no harm by doing it, but you can use it. But none of the guideline internationally or locally said about that.
There are few other questions also, Priyamali. If you can sort of attend to that, by writing some answers, I think they will be benefited. So because of the time constraint, I would like to ask Dr. Ganaka Senaratne to give you the certificate of appreciation. Over to you, Ganaka.
Right. Thank you, Priyamali, for that wonderful talk on neutropenic sepsis. I believe a lot of queries have been answered. So please accept the certificate of appreciation for your cooperation and dedication towards this acute medicine symposium. Thank you so much, and I would like to thank Prof. Aroshit Tanaka, Sudarshan, and the council members, and for giving us this opportunity for the College of Internal Medicine, and Madhuanti for coordinating this event so lively and being the live wire behind everything. So thank you very much for all of you who engage in this wonderful event. I think it has been a real success. Thank you very much, Madhuanti.
On behalf of Sri Lanka College of Physicians, I would like to thank Dr. Ganaka Senaratne, the President, Sri Lanka College of Internal Medicine. And thank you very much, Ganaka, for taking time off amidst your busy schedule. We really appreciate it. And I should thank our four eminent speakers, Dr. Krishanta Jayasekara, Dr. Suranga Manilgama, Dr. Anuja Fernando, and Dr. Priyamali Jayasekara, four specialist physicians in internal medicine, for their excellent talks. And they were very informative, and they all stick to their time limits, and thank you very much for that. And I think I should thank Dr. Ruby Varagado, who was the pre-intern of Ceylon College of Physicians, so doing all the hard work behind the scenes and doing all the logistics. And thank you very much, Mr. Nalina, for your excellent tech support as usual. Thanks again. Finally, I should thank all of our participants. I think there were about 446 participants at one point for joining these, very informative lecture series constantly. And again, may I thank all the participants and all the speakers for your presence today and your excellent talks. And good afternoon to you, everybody. May you have a pleasant day. Thank you very much.